Good morning, good afternoon, and good evening. I am Dr. Mohanad Insour. I am the Executive Director of Eastern Mediterranean Public Health Network, ElFatih. Today, we are going to have a discussion about the Field Epidemiology Training Programs, FETP involvement to meet changing demands brought on by the COVID-19 pandemic. Since the declaration of the COVID-19 as a pandemic, all countries has begun to introduce various prevention and control initiatives. FETPs have been playing crucial roles in preventing and responding to the COVID-19 pandemic. However, many FETPs have been negatively affected by the pandemic, with several being forced to pause the training and other supportive activities. On the other hand, the pandemic has offered FETPs an opportunity to practice, gain knowledge and skills and experience in real-life scenarios. Being engaged with the national health system, the effort of FETPs would greatly add to the COVID-19 response initiative regarding numerous practices including surveillance, case investigation, contact tracing, transferring cases, and risk communication. Within this context, there is a need to evolve existing trainings modalities to respond to changes public health context and demand. Some developments include the establishment of online training models, the establishment of more intermediate and public health empowerment program, basic programs, FETPs in the region. The introduction of courses specific to COVID-19, the development of case studies, and more operational research work that highlights the role of FETPs and their experience and their lessons learned. This webinar brings together FETP experts from the globe, regional and national levels, in a space where they can share insights and engage in proactive discussion toward the future visions and steps that need to be taken to further enhance the role of FETPs in our region and the globe. So the objectives of this webinar are to highlight the role of FETPs in the engagement of and response to the COVID-19 pandemic, to discuss the barriers and effects of the COVID-19 pandemic on FETPs at a global, regional, and country level. And finally, to recommend approaches and measures to sustain the FETPs and enhance their resilience. I hope that we will have a very rich discussion to achieve these set objectives. I will facilitate this webinar jointly with our colleague and friend, Professor Faris Al-Lami, who is a public health expert working in the academia for 30 years, and he is currently the resident advisor for Iraq FETP. Dr. Lam is currently an associate professor at the Department of Community and Family Medicine at the College of Medicine, Baghdad University in Iraq. Dr. Faris is going to introduce the webinar speakers as well. Dr. Faris, please, the floor is yours. Thank you.
Thank you so much, Dr. Mohanad. Good morning, good afternoon, good evening, colleagues. First of all, allow me again to thank Dr. Mohanad Insour and ElFatih for allowing me to participate in this very important webinar and discussing very important topic that is in the heart of the mandate of ElFatih and PhD. As mentioned by Dr. Mohanad, this webinar will look at the changes that FETP in the world region had to make, how they had to resile, and the challenges they encountered on the way. It will also look at how the future FETPs will be in light of the lessons learned from the COVID pandemic. Before I introduce our first speaker today, I just want to run through a few things. First, please use the question and answer down at the bottom bar. If you have any question that you would like to raise or if there is any comment, please use it. And Also, this webinar is being recorded and will be open to all participants after today's session. Now returning to our program, and the first speaker will be our colleague, Dr. Seymour Williams, who is the Principal Technical Deputy for the Workforce and Institute Development Branch within the Division of Global Health Protection of the Center for Global Health at the US CDC. Dr. Williams has written a lot of publication in the field of applied epidemiology and public health. He's a medical doctor. He is a holder of Master in Public Health, and he's also a preventive medicine specialist in Atlanta, Georgia. And he really worked a lot at the state, at the national in the United States, and also international. I remember when he worked in South Africa, I think, for a long time. So, Dr. Seymour, the floor is yours, and you have 15 minutes to present your presentation about FETP evolvement to meet challenges, changing demands, global perspective. Please.
Mm-hmm. Well, thank you so much. Can you see my slides? Are you seeing the right
Yes,
view?
please.
Yes,
yes, please.
Yes.
Okay, excellent. Yeah. So thank you so much for the welcome, and thank you for EmphaNet for this webinar. You know, nothing like being timely, of hitting the time. You know you need something when the situation happens that calls out that need, and that's what has happened with this pandemic. So I'd like to share the results of a global survey we have conducted and completed, which will soon be published, where we learned how FETPs have contributed to the COVID-19 response. Before I share about the study, I always like to, what we call is make sure that we don't just quote statistics, but that statistics are people with the tears wiped away. So before we go on, we need to look at the implications of these numbers. What you're seeing is a heat map taken from the WHO COVID-19 website. And as of yesterday, since January of 2020, there has been a little more than 111 million confirmed cases, including 2.5 million deaths worldwide. And maybe you've seen in the news that the US has reached 500,000 deaths. The Americas account for the largest number of cases and deaths, over 49 million, on over 49 million cases, 1.1 million deaths, followed by Europe, then Southeast Asia, and then the Eastern Mediterranean is next, with a little over 6 million cases and just over 142,000 deaths. These deaths are affecting mainly people over 50, which includes me. And these numbers represent grandparents, parents, professionals that are reaching their prime years, and not to forget the cases that have survived and are suffering sequelae that are not just respiratory. The COVID-19 pandemic has underscored the necessity of the public health workforce, especially FETPs, capable and their capacity to further assure global health security. So for the next 15 minutes, wanted to share a cross-sectional study we've done and to share the results from that. The COVID-19 pandemic, as we've made the point, has demanded a coordinated emergency response effort around the world with well-trained public health workforce, particularly field epidemiologists. Field epidemiology training programs, as you know, train qualified field epidemiologists who build this global health security response and surveillance. Since 1980, when the first FETP was established outside of North America, the Thailand Field Epidemiology Training Program, FETPs have trained over 18,000 individuals in over 80 countries. Early in the pandemic, we heard from partners, networks, and CDC leadership about how important FETPs have been. And I just really applaud EmphaNet for leading the way in your region. To that end, we surveyed programs around the world, inquiring about the engagement of FETP residents, graduates of both response activities, using the framework of the WHO pillars of public health preparedness and response. This survey was conducted between March 13th and April 15th of 2020, with the support of our partners, EmphaNet, the training programs in epidemiology and public health intervention network. And we invited all TEFINET member programs, CDC supported programs, and some regional networks to participate. We asked FETP programs about whether trainees or graduates were engaged in each of these WHO pillars listed here, P1 through P8. And you can see it on your screen, I won't take time, but we ask about country level coordination and planning, risk communication and community engagement, surveillance, rapid response teams, and case investigation, points of entry. And you can already begin to think about, those are some of the things already that FETPs do, but it was good to frame it around WHO pillars because that's many times what countries are using in rolling out response to the pandemic. So 65 programs participated out of 88 that were invited to participate. This is a response rate of 74%. And remember, we're doing things at the program level. The countries served by the 65 programs are presented on this map. The countries vary in complexity from frontline only, such as in Cote d'Ivoire, Guinea-Bissau, the Caribbean, Paraguay, and Cambodia, to programs at all three tiers, like China, Kenya, Tanzania, India, and Colombia. The majority of these programs have more than one tier, and around 70% had an advanced tier. Just some highlights. Presented on this table is the number of countries by WHO region and their median age and range in years. We have the largest number of programs responding from Africa, which also tends to be where you have the recently established programs. They have a median of 8 years. More established programs tend to be from the Americas and Asia with a median age around 19 years. The 65 programs reported engagement. Let me make sure I'm pulling this up. The 65 programs reported engagements are summarized in this table by pillar and FETP status. That is resident or graduate. We are presenting the number and proportions of programs reporting the activity by residents and graduates. So let's say, so this is the punchline of this slide. Overall, 85% of programs reported any resident engagement in COVID response activities, and 98% of programs reported any graduate engagement. Across all activity pillars, graduates are more frequently engaged in response activities compared to residents. For both residents and graduates, the key pillar of engagement was surveillance, the core competency of field epidemiology training. Graduates were more engaged in response coordination. This is not what we call unexpected because they are holding likely leadership positions. Additionally, graduates were active at points of entry activities and which were of critical importance for this particular response. The activity with the least engagement for both FETP residents and graduates was the operational support. And many times, as you can imagine, we don't have residents who have been trained in this type of leadership and management unless they've gotten extra training post FETP. We next used content analysis based on what the free-form people reported on to identify. It's a method used in a qualitative method to identify common themes in the qualitative responses we received. 7 themes emerged from the data that illustrate contributions of FETP to COVID-19 preparedness and response: conducting epidemiologic activities, managing logistics and coordination, leading risk communication efforts, providing guidance, supporting surveillance activities, training and development, and developing the workforce, and holding leadership positions. FETP residents and graduates led and supported a variety of field epidemiology activities, such as contact tracing, sample collection, developing situation reports, and conducting case investigations. This is the bread and butter of FETP. They have been deployed to state, local, and subnational districts while supporting the epidemiologic efforts. As an example, As the Australia program noted, they have graduates working in the National Incidents Room who are involved with analyzing data, developing situation reports, conducting literature reviews, writing guidelines, and supporting state health departments with cluster investigations. Here's a picture of sample collection being collected by members of the Malaysia Epidemic Intelligence Program. Leading risk communication efforts. Many times, you have FETP residents and they are not necessarily trained as the media representative, but they definitely need to develop the messages that go out to people that are affected in the pandemic. And so communication materials, they conduct the risk communication activities, they spread awareness, they combat misinformation and prepared messaging for their respective countries. They have been active in community engagements, including social media, radio press interviews, public awareness campaigns, leaflets and posters, and call centers. In China, they noted that their FETP fellows are in the front line, introducing the public to the national epidemic and risk assessment results, giving updates on outbreak investigations and effective preventive measures. A number of their graduates have also been interviewed through social and print media. In other programs like in Namibia, they have led efforts to teach their communities by establishing a toll-free hotline. FETP residents and graduates have held leadership positions in a variety of response settings, such as in national labs, points of entry, and isolation and quarantine centers. They have provided leadership through coordinating activities at the EOC, Emergency Operations Centers, serving as subject matter experts in risk communication, providing infection prevention and control guidance, and guiding travelers at points of entry. In Thailand, the FETP graduates held key leadership positions and are responsible for incident command and heading the operations team, the situation awareness team, and strategic team that develops guidelines for persons under investigation and outbreak investigation. Here's a picture of a graduate in the South Caucasus FELTP conducting a COVID-19 survey at a marketplace. So I've gone through both the numbers and the stories. And what we have documented here is that FETP residents and graduates contribute and continue to contribute to COVID-19 responses around the world. This consistent engagement of FETPs across all WHO pillars reflects strong program integration with public health institutions. The response activities that FETP residents and graduates have engaged in reflect that FETP trains in competence that are critical to the response. These include EPI methods, including contact tracing, outbreak investigation, surveillance, and risk communication. So findings from this survey have provided direct evidence for the kind of skills that field EPIs need during an outbreak or pandemic. This should inform further training, such as adding or strengthening management and leadership competencies and exploring other methods to provide training remotely. Ultimately, our findings demonstrate the value of FETPs in responding to this threat like COVID, but we were doing it even before COVID. While our survey was conducted fairly early in the pandemic, it might not reflect the subsequent work that FETPs have contributed, and I'll say more about that in a minute. We believe, though, this early survey demonstrates that the skill sets and the expertise of FETPs are exactly what was needed in situations like this. So how do we go forward? What's the next step? So just like I hinted, we need to do a follow-up survey now. We are almost going to be a year or more into the pandemic, and are FETPs continuing to do the same line of work? My suspicion is yes, but as they have gained the experience, they've also been recognized as leaders. So a lot of them might be added to the leadership cadre of their country. So first, as the pandemic and response have changed over time, we are following up to gather updated information to help us learn if and how FETP contributions have changed to the continuing COVID-19 response globally. We are particularly interested in the activities of FETP trainees and graduates in relation to the 9 pillars. You should say to me, Seymour, I thought you said 8 pillars. WHO recognized they needed to add another pillar, which is called maintaining essential health services and systems. You can imagine with all the public health workforce being pulled into response and preparedness, that some regular essential public health functions have been neglected. And yes, we need people now to backfill those positions while we're still combating the COVID pandemic. Secondly, and Mohan may be able to say some more about this from an infinite standpoint, CDC has received resources to further expand field epidemiology capacity. We're focusing on expanding the frontline and intermediate tiers in countries and regions needing this capacity. Given the lessons we are learning about remote and virtual delivery of FETP training, applying these innovations during and post-pandemic will be important to efficiently expand training, assuming we are assuring fidelity and quality of remote training as compared to face-to-face training. Mentoring, as you know, is essential for ensuring demonstration of competence, and it will be important for us to learn what aspects of mentoring can be done remotely. Lastly, in this expansion, there's the need for FETP training to be sustained and owned by national governments, as evidenced by the FETPs having a home in the Ministry of Health, or say a National Public Health Institute entity, having budget and leadership that supports and advocates for the program, and that there are posts developed or in place for epidemiologists at all levels of the public health systems of a country. Let me end by how I started. Thank you so much for inviting me. I would not be able to do my work without a lot of other people that have contributed to this survey. So I just want to acknowledge all the field epidemiology training programs, their directors, residents, and graduates that have provided information for this survey. Thank Tefinet for reaching out, and I thank my colleagues back at CDC. If we can talk some more, and I'm more than willing to take questions during the question and answer period. Thank you.
Thank you so much, Dr. Seymour, for this very fruitful insights on the activities that FETPs are doing throughout the globe. And I'm really interested in this survey that you are doing, and we are looking forward for the coming survey that you are going to do, hopefully in the near future. And it is my pleasure now to introduce the second speaker, Ms. Samar Abdel Noor, who is currently the Senior Advisor to the Executive Director Office at the GHD INFINIT. And Ms. Samar had several positions in GHD INFINIT previously as a Program Manager, Deputy Director, and Director of Center of Excellence of Applied Epidemiology. And she also worked for APT Associate for 6 years, serving as a technical specialist for the research component. She has a master's degree in public health and international health and epidemiology, I think from the same Rollins School of Public Health, same institute where Seymour is also graduated there, and another MSc degree from the University of Catholic University of America. Dr. Samar, she is going to talk about FETPs in the Eastern Mediterranean region, a regional perspective. Samar, you have, as you know, 15 minutes, and later on, inshallah, we are going to have the question and answer at the end of all the presentations. Please, Samar, go ahead, please.
Thank you, Dr. Fares. It's a pleasure to be here. And let me share, I'm sharing my screen.
Yes.
Okay. So good morning, good evening to all, and thank you, Dr. Seymour. It's quite a privilege to have this talk after the survey results and after your talk. I'm here on behalf of GHD INFINIT, and our work with the CDC goes back to over a decade now. Our work started with the support and is still continuing with support from the CDC and particularly from the Field Epidemiology Training Program Division. So in talking about the Field Epidemiology Training Programs in the region, I would like to refer to the Global Strategy on Human Resources for Health, which was later on referred to as HRH. that was issued by the WHO in 2016. And this strategy emphasizes the role of health workforce and health workers in strengthening health systems, and highlights the important role of health workforce in building resilient health systems that can prevent, prepare for, respond to, and recover from emergencies and disasters, whether they're natural or man-made emergencies or disasters. And I think this puts the FETPs into a good context if we think, or if we consider COVID-19, and if we consider FETPs and the support and the need to support and strengthen field epidemiology in order to move forward with this HRH strategy. So at GHD EMFNet, the work with the FETP is situated in the heart of the Center of Excellence for Applied Epidemiology. And this center was established by GHD EMFNet in 2015 to achieve prominence and give emphasis to applied epidemiology. The center looks at or seeks to create opportunities to strengthen and support applied epidemiology regionally in all the countries while capturing trends in innovation and learning. The center also strives to advance applied epidemiology to promote public health policies and practices through operational research, through the use of innovative technology, and spreading knowledge and sharing knowledge and networking among FETPs, among those people who work in public health, specifically with applied epidemiology. And workforce development is the center for that. And in looking at the presentation of Dr. Saimour and hearing him say that building valuable workforce capacity is critical to public health emergency, I think this is the heart of our work, the FETPs and the Center of Excellence. So our work as a network started with 4 FETPs back in 2009. These FETPs were situated in Saudi Arabia, Pakistan, Egypt, and Jordan. In 2014, Morocco, Iraq, and Yemen joined the network to yield 7 programs. And in 2019 and up to this date, we have 11 programs, 10 from the region, and 1 that was recently established in Bangladesh for FETP VET. And the recent additions to the network and to FETP network particularly were those in Tunisia, Sudan, and Afghanistan. In looking at the FETP modalities or FETPs in general, we like to think of the tiers, the different tiers for the FETPs highlighted by the advanced, which is a 2-year program. So 8 of our countries or of our programs have advanced FETP. 3 of the programs that we have in basically in Tunisia, Afghanistan, and the Bangladesh VET have intermediate program. This is a 9 to 12 months program. And recently Iraq was added in 2019 with its intermediate program. The base or the basic field epidemiology training program is what we refer to as public health epidemiology program. In other regions and other countries, they refer to it as a frontline FETP, but we like to look at it as FEP for basic field epidemiology. We have the basic or FEP in 6 of the countries, and we're looking into increasing that and increasing the number in the different levels. Currently, the programs that we have yielded several cohorts, and the cohorts depend on when the program was established. So the most recent programs in Sudan and Afghanistan have 1 cohort so far, and the oldest program in the region is that in Saudi Arabia, which has 32 cohorts. And in looking at these cohorts and the number of graduates and looking at them in terms of intermediate, advanced, and both, as I said before, Iraq maybe is one or the first country to have both advanced and intermediate program. Most of the countries started the FETPs with the advanced modality. But quite recently, in the last year or two, countries started looking at the intermediate program more in terms of wanting and demanding more graduates of the program within a shorter time frame. The number of cohorts is not directly related to the number of participants, because each cohort or several cohorts might have different number of graduates. When we look at the FETPs and our work with the FETPs, we basically start with looking at the FETP, whether advanced or intermediate, and strengthening the current or existing programs, as well as looking towards establishing new programs. Another thing that we look at and we like to give prominence to, and I believe Dr. Saimour also referred to the basic, or what we call the FEP program, as core towards improving or responding to public health emergency. We also like to think of operationalizing our work in terms of supporting FETPs by having an enrichment program and offering fellowship and exchange and scientific writing program to help the FETP graduates and residents perform better or in a more enhanced way. So how do we work, or what do we do to strengthen field epidemiology in the region? We always look at opportunities to engage the FETPs, whether residents or graduates, in developing and implementing or evaluating public health programs. So when we work with countries, we always try to engage FETPs in our work. We support existing FETPs and establish new ones, whether it's a different modality or whether it is a new program in a new country. We also work at developing online training programs in various public health fields or issues to enrich the FETP's competences, and not only in field epidemiology, but in other areas as well. And we always look at improving the quality and value of FETPs, including evaluations, and try to strengthen FETPs' field missions and their work in the field and in their response activities, as well as support them during deployment, whether in country or between countries. So when I refer to enriching FETPs, we're always looking for opportunities to enrich FETPs, residents and graduates. And examples to this is this webinar, which is part of an EMFNet Webi series that we launched in 2020, basically targeting FETPs and public health professionals through discussions that are online. We also highlight the work of the FETP and their achievements through an FETP newsletter. Another example for enriching FETPs is the EpiShares, which is a networking platform where public health experts come together, they share experience, they share news, and FETPs have the opportunity there to dialogue or to connect with other public health professionals. So what happened in 2020? What happened, I don't want to say the year, COVID year, I would like to call it FETP year. I think year 2020 gave prominence to the FETPs. We can all agree that everyone knows all around the world now what contact tracing is, what epidemiology is, what an outbreak is, which was not the case before COVID-19. So that's something positive to look at. And what we did from 2020, and it's not only related to COVID-19, but the plan was to bring in more opportunities to FETPs. And it so happened that we had the chance to customize the 3-month program, the basic program or FEP program, to address COVID-19. So we had the program there. We had that program, the basic, the FEP, in 6 of the countries. So in 2020, we customized that to address COVID-19. We also, up to date, have 17 case studies, and we are increasing publications, recently more with COVID-19 publications. So we have 75 scientific publications from our work and the work of the FETPs from the region. During 2020, we developed our learning management system and offered online trainings. And the 3 courses that we started with were rapid response, risk assessment, and infection prevention and control. And when looking or hearing Dr. Saimour talk about the survey, I think risk communication was there as well as IPC. We helped countries train rapid response teams, and we supported FETPs response missions, as well as supported developing and printing promotional material. In looking at the online basic field epidemiology for FEP, the FEP basic field epidemiology program, FETP, is a 3-month program that CDC developed. We customized that with a focus on the core competencies of FETP, and we will be launching this program online for the first time. I believe this is like the first time in the world to have this program. So our online learning management system came as a result of a need or a demand, and the demand was rapid. Countries wanted an online system or e-learning system, and as everything else during COVID-19, everything changed and education changed as well. So we provided, or we came up with the learning management system, LMS, which is our own, and it is free and open source. The focus of this was, the focus was this, was to enable interaction between the instructors and learners through distance learning. And we thought that this is effective because it is effective in terms of cost, in terms of time, and in terms of retention. The learning management system that we launched in early December offered, as I said, the 3 courses on infection prevention, control, rapid response, and risk communication. We provided this in 2 languages. It is free and self-paced learning system that anyone can reach through lms.mfnet.net with a certificate of completion given at the completion of the course. To date, we have over 1,500 enrolled people in either of these 3 courses. Some are enrolled in 1, others are enrolled in 2, and some have even completed 3 courses. More than 800 have, or like half of these have completed the courses, and work is still in progress for others. From the FETP community, the enrollment was about 40%, like 600 people who were FETPs enrolled in these courses, and more than 200 completed these 3 courses, 1 or more of these courses. So in summary, we have 10 FETPs in the region and 1 in Bangladesh. These FETPs yield more than 100 cohorts with 1,500 plus residents and graduates. And the basic or FEP for basic field epidemiology has 500 plus graduates, and work is in progress in increasing these in the 6 countries and more, with new FEP in new countries. Altogether, we are working with the countries, with the FETPs, to have more case studies that can be used in the trainings and in situations or in specific areas, teaching areas, particular to our region. We held 6 conferences, regional conferences, with more than 1,000 abstracts presented by FETPs from the region. And as I said, 75 peer-reviewed articles have been published. The heart or the core for having good FETPs or for enhancing the FETPs comes from FETP evaluation. So we always work at ensuring the quality, and we work at adding value for the FETPs, specifically evaluation for the newly introduced online approach through the courses and through the online FEP that we are launching soon. So we're working on evaluating FEP and intermediate FETP. The evaluation is centers around process and output indicators. And FETP remains our flagship program. It is where we started, and we will continue to collaborate with countries and to build new FETPs and strengthen and support the current FETPs. And back to the HRH, I think the more we work in supporting FETPs, we will have a stronger public health practice in the region, and the health systems in many of the countries in our region which are suffering already will be able to better respond to and recover from emergencies and from disaster as we improve and enrich our programs. I just want to end by an announcement. We, as part of enriching and having more exchange between the FETPs in the region, we're arranging for a symposium for regional COVID-19 operational research, which will be at the beginning of April 7th and 8th. And the submission for abstract is open, so you can reach to our website or to any of our social media for more information on this. And if you know any FETP who has worked diligently during COVID-19 and maybe like to share their work, this is the place that they can exchange information. Thank you. Over to you.
Thank you so much, Samar. Thank you for shedding the light on the important activities that FETPs in the region are doing, particularly during this tough times of the COVID. And as you mentioned, it is FETP year, in addition to being COVID year. So it was a challenge indeed. Now switching from the global to regional, now we are going to have some insight from one of the FETPs in the region, from Sudan. And it's my pleasure to present our third speaker, Dr. Shahed Osman. Dr. Shahed, she is the FETP technical advisor for Sudan FETP. And in addition to that, she's also working in Ministry of Health in the Public Health Institute as education and quality specialist. In addition, she is a lecturer in a number of universities in Sudan. Her keen interest in epidemiology, communicable, non-communicable disease, as well as evidence-based medicine research methodology and research ethics. She's a medical doctor. In addition to that, she has a Master of Science degree from the American University of Beirut. So please, Dr. Shahed, the floor is yours. You have 15 minutes to present your slides. Go ahead, please.
Okay, thank you, Dr. Faris, for the introduction. I shared my screen. Is it clear, the screen?
Yes, yes, please.
Yes. Okay, thank you, Dr. Faris. As you said, I will focus on the local context, taking Sudan as a case for what happened with the field epidemiology training program and the effect of COVID-19. I think my presentation will be pretty much aligned with the two previous presentations, but with more focus on the context. So in the beginning, I will talk a bit about Sudan just to introduce you to the country so you can follow up with our situation and our epidemic profile, then how FETP was established and when. Then I'll talk about the general context we're having, which I think COVID added to, and the activities that we were able to conduct through the FETP program, through our graduates and now our residents. And then I will finish up with a conclusion and major recommendations. So Sudan is a low middle income country. It is situated in Northeast Africa. It is the third largest country in Africa. It has been the largest, but after the secession of the South 10 years ago, it's the third. It's bordered now by 7 African countries and the Red Sea to the east. It has a tropical weather with wet and dry seasons. Sometimes we have droughts, sometimes we have floods. So this is the general picture of the country. When it comes to epidemics, the epidemiological profile of Sudan is dominated by communicable diseases. And they are the main causes of morbidity and mortality. But this is also complicated by geographical dispersion of the population, by periods of armed conflict, and by natural disasters such as floods and drought, as well as issues with malnutrition and other diseases. For FETP, it was for the country, it's quite obvious that we need the program and we need field epidemiologists given the country profile. And there were a lot of attempts throughout the years to start FETP, but there were issues due to sanctions and the isolation of the country during the previous regime. But however, FETP was started after a multi-sectoral international external evaluation in 2016 that identified huge gaps in applied epidemiology. And one of the recommendations was to set an FETP program, and through a very fruitful collaboration between the Federal Ministry of Health and the Eastern Mediterranean Public Health Network, we were able to establish FETP in 2017. So our first batch of FETP was actually started in 2017. The objectives are similar to other FETPs. The curriculum even is similar. It's based on the CDC curriculum, but has been adapted to the country a bit. So it's to build the capacity of the health system in surveillance and outbreak response, and to assist the government in decision-making for achieving a global health security. Our first cohort from November 2017 to November 2019, we have 14 graduates. Our second cohort started September 2020, and it's right now they're in the field. We have 10 residents. This is the map of Sudan, and we have 18 states in Sudan, and we have our graduates from different states. So we have, we're covering around 12 states. We have graduates or residents, either a graduate or a resident in 12 states. The bulk of them are in Khartoum. So we have 6 in Khartoum at state and federal level. And we have some in Darfur, some in Kordofan, some in, so we're trying to cover most of the country, even though the number is very limited. So we have, till now, we're just at 24, I can say 14 graduates and 10 residents, but we're trying our best to have them everywhere. We're still baby steps. So now I'm going to talk about the context, and I'm going to focus on the years where we have had the program, because we had the first batch started, as I said, at the end or towards the last quarter of the year in 2017 until now, so it's like 3+ years. Sudan had several epidemics, regardless of this. So we had cholera, we had diphtheria, we had malaria, we had Rift Valley fever, we had dengue, we had chikungunya, we had COVID-19, the cherry on top, and we even have vaccine-driven polio. And when I say these, to list this, this is not a one-time, one-place outbreak. So we can have these outbreaks. So chikungunya, for instance, happen in like several states in different times. Dengue, others, malaria in the 18 states. So I'm not talking about just like 8 outbreaks or so. I'm talking about these occurring several times in different areas. I'm also giving this the leadership, because for us, a new program, we need to look at the leadership and convince it, because we need all the time to to sustain the program, FETP at the beginning at least leads some sort of leadership and political support. And the previous slide just showed 8 ministers of health during this period. So I have two cohorts and I have 8 ministers, and it becomes sometimes very difficult. And this represents just the amount of turnover we have at the level of the country. So we have very high staff turnover. So even when, because we have those residents, they go to the field, they have field supervisors, even if they are working in the epidemic department, there's a huge staff turnover, and this becomes very, it's like a vicious circle of you need to train, you need to advocate more, you need to get the buy-in, situate them in the proper place in the program. And then we have also the natural disasters. We had floods in 2019, we had floods, huge floods in 2020. We have an economic inflation that is pressing really the program in so many ways. There's also the internal factors of everything new, the resistance to change, and the technical capacity in remote areas. If I want field supervisors in remote areas, and they have never been trained on FETP because it's a new program. So this is also a limiting factor sometimes, and it puts in a challenge. And also, of course, the resource constraints. Setting that apart, we also have incidents of armed conflict. For instance, in the Jenin area in West Darfur, where we do have residents. We had a resident in the first batch, and we have a resident now. There are influx of refugees from South Sudan, for instance, in the previous years, and recently the issue in Ethiopia and the refugees over there. So this is the general context we're dealing with before or with COVID-19. So there's a lot going on, and that's why Sudan can be a special case, but still, I'm sure in the region, in the Eastern Mediterranean region, a lot of other countries can relate to this combination of factors. For COVID-19 in Sudan, the cases till the 21st of February were 28,210. The deaths are 1,876. Our first case was on the 13th of March. Then there were mitigation strategies, some shutting down schools, curfew, complete lockdown. And then the release of the lockdown happened in July. And then we have a period of where cases were dropping. And then the second wave started in October, which is now also dropping, but you never know what to expect next with COVID. So how did COVID affect the training? In so many ways. For instance, we wanted to start the second patch in the March, but we couldn't. That was when the first case was announced in March. And then there were all those mitigation strategies, putting in travel limitations, especially between states, and most of our residents come from states, and we even train the supervisors, we bring them from states to be trained in Khartoum. So there was a delay in everything. We couldn't initiate the program, and even like because the bans of gatherings, and so we could not start and initiate the program. So it was delayed for quite 6 months. We actually started in September. The travel between states, as I said, was very difficult. Even we had projects planned, so we wanted to do a chikungunya risk assessment, and we couldn't because we couldn't travel. We changed it to secondary assessment. By the time we wanted to submit it, we lost the funds. So you have disruption in our projects or whatever we're planning. And there comes also the prioritization of activities. So sometimes you have a fund allocated for something, then you say, no, COVID is the urgent pressing, so you put it there. And then comes the floods and you go like, no, COVID is not the urgent pressing, let's focus on the floods. So 2020 was a challenge to planning because you have to be alert and you have to be more ad hoc and you have to be flexible to manage and get the program through. But even with everything happening, perhaps the most devastating or the most the greatest drawback or setback for us was the loss of one of our colleague and of our mentor and advisor, Professor ElFatih ElSamani, who taught the principles of epidemiology to the first batch and the second batch. And he was with us from the beginning of COVID-19. educating people about it. And ironically and sadly, we lost him as well for COVID-19. But then let's look at what did we achieve as a program with COVID-19. So there was a lot with rapid response teams. We conducted several trainings. This training, for instance, within Jazeera State before even we announced the first state, and FETPs participated in this. And we also conducted trainings in Khartoum State for rapid response teams. We're proud to say that we conducted the first workshop targeting frontliners. So we conducted this workshop at the Sudanese Medical Specialization Board, and it targeted the doctors. A lot of trainings were done before that, perhaps targeting public health and community, but this was targeting doctors, and we produced even messages for them. This is part of the training. So yeah, we produced like pamphlets, we conducted risk communication. We had posters, we had these key messages using small brochures for doctors, and even we conducted risk communication within the community. This is even for this last picture. This is a current resident in Red Sea, conducting risk communication efforts. And as the first presenter stated, most of the activities were also around surveillance. And FETPs, they conducted a lot of surveillance activities, and they also trained on surveillance. So surveillance was also a strength for us. And we had also our residents in points of entry. So we had them at Khartoum Airport. They also managed quarantines. They would also monitor arrivals. We have in different areas, even this, the second picture is from one of our residents in West Darfur, so in Jenin Airport. And we had them conduct many activities over there. In planning, our FETPs were there with committees. They planned, we have FETPs in the Case Management Committee, Epidemic Intelligence Committee. They participated in putting plans for the states. They participated in supervision. Even this last picture is like from an FETP visiting one of the special communities, like in a prison, to look at the COVID mitigation efforts there. So even though we have a very small cohort, we felt that they had a good impact given the situation in Sudan, and they were supportive. Also in case management, here FETPs are in hospitals, they're in isolation centers. They're also, the program was setting protocols. The program even conducted a survey to see the burden of the disease in Khartoum when there was issue about the numbers. So there were a lot of things that were being conducted by FETP, even though we faced so many challenges. But still, I will say the challenges are access. So you want to access the training. We felt the delay was long. We felt even the modalities, we were thinking all the time. We did think of ways to mitigate that. So for instance, even when we were like, we wanted to conduct interviews for the patch, we decided to go for conference calls instead of face-to-face, and it worked out. We tried to utilize some of the resources that are offered by the regional and the global network. So for instance, for scientific writing, we relied on the scientific writing course Stefanot has produced, and then we just got instructors to just teach a bit of elements to discuss actually the course with them instead of giving it all face-to-face. But still, there's also the access of technical support, because we have a very few residents dispersed in areas, and sometimes you want to be able to support them more. And we also need support from the region and global support, but COVID-19, everybody is very busy. So we felt, sorry, even though information is available, you feel still the actual technical support sometimes is obstructed by whatever is happening. And then the access to resources, because there's a lot of competing resources and everywhere throughout the world. Our conclusion is like COVID-19 has affected the implementation of our planned activities in 2020, definitely. But it also showed us the importance of the program, and that we do have a shortage in epidemiologists, and we do need more empowered field epidemiologists. And as previous speakers have said, COVID-19 still served as an opportunity for our residents, and it was a very good learning for them, which ironically we fight epidemics, but when they come, we still benefit from them at a learning level. Finally, our recommendations is to try and guard against COVID-19 collateral damage. And I'm saying this because at a level where a country has so many epidemics, sometimes if we focus on something, the urgent, the need, then we miss our own problems. So we need to guard against it without like neglecting COVID, because COVID has been a very devastating experience and still is until we can get rid of it entirely, hopefully. Virtual learning brings us together. So previously we would like face-to-face learning because it's more interactive. People feel they're like they can interact with the instructor. It's a safe space. But now when we're forced to stay at home and when we're forced to be apart, virtual learning is actually the mean that brought us together. So because there used to be a resistance always, I don't know, probably in Sudan, because people are not used to it and internet issues and stuff, there's a resistance to virtual. But now since it's came, people now need it, and people are now more open to it. And I think we have to capitalize on this opportunity and build on it, because it also helps us produce more FETPs, and this is something that we want to do, and be able to even connect more and share experiences. And this is something that we really need at this time. And I think the entire world now knows that we are in this together and we do need to share experiences. I think this is my last slide. So thank you.
Thank you, Shahad. Thank you so much for this very informative presentation and really enlightened the situation in Sudan, as well as the FETP activities, really inspiring activities I can see. Thank you for all the speakers who were very committed to the time as well. And we have now something like 30 minutes will be left for questions and answer. I will hand over to Dr. Mohanad. Dr. Mohanad, please.
Thank you very much, and thank you for all speakers. I think we will have 25 minutes for questions and answer, then we can conclude by the remaining 5 minutes. So regarding the questions, I was seeing that we have question to Dr. Saimour about what advances we would expect on FETPs in terms of learning and the practices in the future. Please, Dr. Saimour.
Thanks for that question. Well, I think we're seeing it here. EmphaNet has already piloted and is rolling out a learning management system. And as not just cell phone coverage and internet connectivity improves, what we're doing right now was not possible many years ago, where we would all be having to travel, be jet lagged, and have face-to-face meetings. Now we can have face-to-face meetings in your time and in my time. So I think we need to, one, underscore that the pandemic has forced us now to do webinars, to do learning management systems online. So that, I think, is the future. We can't get away from it. What I am worried about, and this is how you have to be careful of advances, just because we can talk, I don't know what you're doing if you're really paying attention. So in a learning environment, what are we doing to ensure that the fidelity between face-to-face learning and online learning are the same, especially if the person is distracted by multiple other things? And that's just the learning part. What about mentoring? How do I validate that you have attained that competency of being able to analyze your data, of being able to bring stakeholders together, of being able to speak to media in a clear way? Does it still need us to have some face-to-face time that requires presence, or can this be done remotely? So I think the didactic and the field work, need to utilize the technology, but somewhere along the line, we need to know where the limits of that technology is to assure competence. But that's a wave of the future. Over.
Thank you. Thank you very much. So the second question is to Samar. So we had this question, Infinite has introduced the online modality for the FETP training. What are the main expected challenges with this modality and how we can better plan for them with partners? And there is another question related to this, if we can do the full virtual model for FETP. And I think we have many questions about the online modality. Please, Samar.
Yes, thank you. Thank you, Dr. Muhannad. I think that this is very challenging, not only for FETPs in our region, but throughout the world. I think that the emphasis on changes in education, not only in the world of the FETP, but generally during COVID-19, has enhanced the online education. So basically the main challenge that I see is the ability to monitor the uptake of the knowledge, as Dr. Seymour maybe mentioned. This is very challenging. When you have people in a classroom, you can interact more or in a different way than when you have them online. And since the online is self-paced mostly, so you cannot manage or challenge people against each other. So one of the main challenges is to keep people motivated at the same level and at the same time. And I think with the FETP intermediate, GHD Infinite is working on having that online. So it's only time will reveal how effective that is. So it's we're going through changes, and all changes come with challenges. So I think the main challenges is to keep up with what we started in terms of online modality. Maybe there is a need to have a different modality that is online and to test it against what is there. Not sure. Thank you.
Thank you. Thank you. So I think the third question to Dr. Shahid, and this question becomes from Afghanistan. And our colleague Islam Saeed is asking about how to get attention of leadership of countries to FETP and its importance after the COVID-19. So it seems to me Afghanistan has the same challenge with as Sudan with the leadership and etc. Please, Dr. Shahid.
So yeah, for us, this is very important because the changing leadership. So once we have the buy-in of a leader, comes another one. So, but the ironic thing is with COVID-19 and the epidemics, leaders are more likely to listen to whatever we want to say about FETP because they know right now that epidemics are a great issue. So it's easier to access them. It's easier to say, we have this problem, you see what's happening, and just to demonstrate whatever the efforts of FETP are doing. So what they really want to know is, what can we do to change this? It's not like supporting a training program, it's supporting the system. It's offering a service. It's not just them investing in something that is actually taking away from them, but it was actually building the system.
Thank you.
Over to you.
Thank you very much. I think all of our countries, majorities of the countries, we are suffering from this sometimes, the leadership issue and senior management. So we keep struggling with this. I think with time, FETPs needs to be sustained and to be considered part of the health system in our countries, and this is what we need. That's why, colleagues talk about, the importance of sustainability. So back to Dr. Seymour, we have a question about how the engagement of FETPs graduates toward activity pillars was measured in your study. So
Mhm.
this question about, activity pillars was measured, please.
This is a self-report at the program level. So
Mhm.
remember, the survey was sent to like program directors, resident advisors,
Yeah.
and they essentially answered, are residents involved in point of entry work? We didn't get down to the exact it's like number of residents that we're doing. They just had to acknowledge in the 8 pillars that were in the original WHO pillars of response that we queried. So it was self-report, it was a cross-sectional survey asking at one time, and it was reported at the program level.
Thank you. Thank you. So, Dr. Shahid, it's back to you. Second question, it's about the outbreak. What if Sudan was ready, because Sudan has many different outbreaks before the COVID-19. So does this was easy for the program to enhance these activities after COVID-19?
Enhance the activities of the outbreaks,
Yes.
other outbreaks.
Yes.
So I think other outbreaks at COVID-19, once it began in March in Sudan, as if we dropped in other outbreaks. And I'm not sure if this is the issue. Yes, the period perhaps between March and July, it's not the most affected, but still, I have to say that we might have overlooked things happening. And that can be like seen from, like, for instance, when we pick up the polio outbreak or so. So we put our focus on COVID. COVID is different, the transmission is different. So we're used to like a vector borne, we're used to like, for instance, diarrheas or so. And the transmission of COVID makes the pressure more, and people tend to focus on it because previously we were not hit as much with other like types of airborne diseases, like SARS and stuff. We're not hit as COVID. So the experience is a bit challenging, and all the efforts are there, and all the resources are there, and there are constraints, and there are mitigation strategies, and as I said, there are also economical issues. But eventually the momentum came. So eventually Sudan started to focus on other problems that are there. So I think now we're on a much better status than at the beginning. But if I tell you that, do we have statistics of what did we miss or what is there, it would be quite difficult to have an accurate like a judgment of, yeah, what happened? Were we able, or there was nothing? Over.
Okay. Thank you, Dr. Shah. Ms. Summer, it's about what lessons have been learned from the pandemic that could be used to enhance FETPs in general, please.
I think one of the lessons that we learned, major one, is how quickly can we respond to the needs of these FETPs, and how can we support the FETPs in the field as strongly as we can. How can we engage them? I think looking into virtual solutions, into digital solutions, to provide support to the FETPs in the field, and perhaps have the work, because they're out in the field, and during COVID-19, it's not like a regular outbreak. There's so many things that they need to do. There's so many things that they need to learn and in order to respond and work and investigate. So I think our ability to be in touch in terms of the needs, responding to the needs of the FETPs. And an example to that, I think, is the LMS and the courses that we provided. So the courses that we have out there, FETPs can engage in and benefit from at their own pace, wherever they are. So I think this is the future in terms of needing to look into more use of digital solutions to enhance and strengthen FETPs and to get them engaged and increase coordination between and exchange also between the different programs in different countries. Maybe not only to look at the lessons, we need to look at the challenges as well. I think with Dr. Saimour's survey, maybe we can have or tap into what differences are there between the different FETPs between the regions. So we are aware of the needs in our region, but what about the other regions in terms of COVID-19? This can allow us to exchange more between the different regions across the globe. So it's one world, it's one FETP. It should be maybe the role of Definite in this can be more enhanced. Thank you.
Thank you, Samar. Thank you very much. So, okay, still we have time. So back to Dr. Saimour. And here our question, are there any efforts and resources to put on One Health approach into action? It's about One Health approach. Good question, please.
I just started writing my answer to that. Great. It's amazing. I mean, Samir just pointed out that it's, you know, animals are moving all over the place. You know, I heard about in the Mediterranean, there's just ship out there filled with all these animals, nowhere to go because they have blue tongue. So not only are people not getting their cows, there's an outbreak on the ship. We can't get away from it. I think the statistics say 70% of our diseases is actually coming from our interaction with the environment and with One Health. But here's our issue. When we try to do it, it's like we have a hard time enough bringing the ministers of health together. Imagine bringing the Minister of Health and the Minister of, and put them in the same room, Minister of Agriculture. It's becoming really, really hard to do that. And many times people become, for want of a better word, very sectarian. They're keeping the resources to themselves. So what I think we need to see are more examples at the country level where when you have an FETP, that intentional efforts be done to recruit vets and environmental health scientists. There's two reasons to do this. One is so that they will know each other. When I was an RA in South Africa, I got really, really upset when kids would die from rabies because many times it was the medics weren't talking to the vets or the vets weren't talking to the medics. And so we need to train them together so that they know and how to reach out to each other. So we need to tweak curriculums that will make it both beneficial to the vets and to the medics. The other pieces that's missing when people say One Health is the environment. We've not figured out how to incorporate the environmental health officer into true One Health. So need more country examples. We're willing to support it. We need the curriculum that will do it. There are some groups that are supporting just vets alone and para-vets. That's great. But what we want is an integrated training, both for animal, human, and environmental health officers sitting in the classroom getting to know each other, because these big three components are what's driving some of the new health profiles of countries. Over.
Thank you. Thank you very much. Just if you allow me to add from our experience in from the region, that we tried to do that in the past, in the past 10 years in a couple of the countries, but unfortunately, I don't think we were successful enough. I think the training and the curriculum, maybe by itself, it was not ready at that time. Maybe we need to do a lot of more work about this. And now there is a global discussion about having FETP vet, which is, a special track for veterinarian. So we hope that we can do something, especially nowadays. 65% of our outbreaks are originally from the zoonotic, etc. So this is very critical issue. This is very critical matter that we need to consider in the future for our programs. Thank you very much. So, Dr. Shahad, our colleagues are concerned about the sustainability of Sudan FETP. So how we can make sure that this program will be sustaining later on, Can you tell us about the sustainability plan or ideas, how we can help the countries in this regard?
Yes, for us in Sudan, we have like the strategy, an FETP strategy, and we want to produce, be able, as colleagues have spoken earlier, to have all the levels. So we want to start right now an intermediate FETP, and also to have more. We have FEP, but we produce more. And I think right now, because we're focusing on how to have a career path for them that is apparent in the federal ministry, if once you're an FETP, you have better opportunities and it can be recognized. Because if residents don't feel that it will promote them in a way or another, right now everybody knows the value of FETP, but still within the ministry, because we tend sometimes to lose some of them, even with those two cohorts. Thankfully, we lost them inside the country, so it's fine. But still, you tend to lose FETPs once they get better opportunities, and it's such a need. But I think right now it's quite recognized in the ministry, the importance of the program, or at least it's recognized the importance of having field epidemiologists. And that's a support, but definitely the sustainability also is limited by resources. And we're trying to mobilize every kind of resource we have and build like meaningful collaborations, even with, thankfully we have the support of ElFatih, but even with WHO and CDC and other partners.
Thank you. Thank you.
Over to you.
Thank you. So maybe we have another question about, let me check. We have many questions actually. And just, allow me to mention here that we will answer all these questions and we will share with you a report of this seminar. So usually we disseminate reports and just from this. So if we do not answer all the questions or we do not have enough time, we will make sure to answer all questions later on. So here we have a question regarding linkage, the FETP in general. The question is from Egypt, but let me state it in general way about the importance of linkage, the FETP with the academia and the global experience in this regard, please.
Is that mine or is that Samir? Okay. So we're all academics here. We trained in academic institutions. But I want to share at least a couple experiences. Whenever we let an FETP program become embedded in an academic institutions, what we've noticed is that the trainees focus on getting the degree more than focus on making a public health impact at the Ministry of Health. And so we are very cautious, and we've had to stop supporting programs when it became an academic exercise. We are not here just to grant people degrees. We want them to get degrees. And I noticed one of the questions asked about whether this is a community medicine fellowship. It's great. But if they're not doing work that's practical at the Ministry of Health level to deal with the public health priority issues of the country, it's an academic exercise, and we are past that. COVID, if anything, should teach us this is not an academic exercise. We're talking the life and death of people. And that's why I headlined my talk with saying COVID is this unfortunate thing that has happened, but it's highlighted the need for people who can practice epidemiology and make a difference. And Samir, you highlighted it in the New York Times editorial. One of the epidemiologists who was asked, what do you think will cause COVID to change? And that's what the person said. No longer will we have to explain to anyone who is an epidemiologist. It's not a dermatologist. It's not some funny other name. It's people who count, measure, and find out what's happening in a population and survey and make interventions for action. So yes, we need the academics. Yes, we need their support, but I think the linkage should be joint. We will help you with the didactic, but you'll get your degree, but it must be things that are making a difference for your country. sorry to come off so strong, but we don't want just people to have degrees. We want them to practice epidemiology that makes a difference. Over.
Thank you very much. I totally agree. And I think we have 5 minutes to conclude and come up with few recommendation. Again, my sincere apology if I did not capture all his questions, but we will make sure to answer all these important questions. I saw many interesting and very vital questions that we need to back and answer these questions. So Dr. Faris, would you like to conclude, and we can do this together? If you can start, please.
Yeah, thank you so much, Dr. Mohammed. In fact, great points have been raised during the discussion, and I just would like to highlight very few points that are really remarkable from my perspective. I think one of the most important issues that's been highlighted in the three presentations, in fact, is the issue about maintaining essential health services during the outbreak or during the pandemic, and the collateral damage that should be mitigated during these events. I think this is very important, should be considered and should be thought of. Otherwise, we will lose more from the collateral damage than the incident itself, or the pandemic or the epidemic or whatever. The other very important issue, what other capacities and competencies that we need, our residents need to have during their training, considering the gaps that had been highlighted during this pandemic, and on the top of these, probably the issue of public health management and leadership. A very important issue that also I would like to highlight from the three presentation, the issue about exchange of residents and the graduates, which I think is very crucial in order to share experience between different countries. And again, I think even in the region, probably we didn't have a great success in this area, because there are some bureaucracy, some admin issues, something between the countries, and so on. So again, I think probably that it's time to think about how to address this point in a very constructive way. Another point that I would like to highlight is the Field Epidemiology Day, which we have hear about that, and it is time again to advocate for that, because to give the recognition for the field epidemiology. And again, I think this can be a response to one of the questions that had been raised of one of the colleagues about the sustainability, number one, and about how to give a recognition for the programs in front of the policy makers and the leaders. Having that in mind, having that in public, this is going to make such a recognition very clearly. I really admire the work that had been done by EFNET and the Center of Excellence of Applied Epidemiology in the area of online training, particularly the rapid response team, infection prevention and control, and the risk communication. In fact, in Iraq, we had disseminated not only to FETP, we had disseminated to everybody who is concerned with and working in the area of public health, in order to gain experience and gain the necessary knowledge in this particular area. So from my perspective, these are the most important points that I would like to, considering the time. I have more others, but I think Dr. Mohammed, would you like me to go through the recommendation, or you would like to go through?
Please.
Thank you so much. We had agreed on some recommendations that I'm going to go quickly. First of all, there is a need really for increasing the number of trained field epidemiologists globally, regionally, and nationally to prevent, detect, and respond to public health threats. Secondly, the need also is for expanding the target of FETP trainees and to go beyond medical doctors to include other sectors under the umbrella of One Health approach. And you just talk about the veterinarians, but we have all others, in fact, laboratorians, pharmacists, other people as well. Establish more intermediate FETPs and basic field epidemiology in all countries. It is time to go to the grassroots level and train those people who are at the districts and below the district even. Those people who are the first responder, who are the first informer, and we have to invest in them. 40, customizing the FETP curriculum to incorporate the needs that are revealed by the COVID-19 pandemic, including the development of regionally customized case studies and exercises, in addition to the competencies that I just highlighted as well. Another point is adopting new training approaches, teaching methods and tools for the FETP, such as blended programs that combine online and face-to-face training. In fact, in Iraq, this had been now a system because we are obliged to do that, in fact, but it seems to be very, very successful and very fruitful indeed. And meanwhile, it minimizes the cost as well. It is time to think about this. Also invest more in e-learning modality, making use of the advances in technology and the experience learned from the COVID-19. Complement FETP with developed and the provision of specialized training courses for public health workforce to ensure greater sustained preparedness for future pandemic. I think as far as the interface between human and animal getting closer and closer, we have to expect more and more pandemic, and as Dr. Mohanad mentioned, probably more than 70% of re-emerging disease and pandemics will be from zoonotic disease. So it is time to think in advance. Development of a regional framework and strategy to sustain the FETP in our countries. And very important point that had been raised by Shahid, and we have to capitalize on that, in fact, how to retain those people. There are surrounding countries who are going to take those people from you. We have to think how to retain those people inside the country. Also empower the FETP Alumni Association and promote the long life learning among graduates. Promote the exchange program for FETP for better qualified health workforce as highlighted area. More focus on the area of operational research and the use of digital solutions. And lastly, expand and strengthen the FETP network in the region through various approaches like conferences, FETP webinars, and the newsletter. And I think this is part of these activities, and really InfNet did a lot in the area of webinars, newsletters, and EpiShare, etc. Now, thank you so much, and back to you, Dr. Mohanad.
Thank you very much, Dr. Faris. It was very great summary. So at the end of this webinar, I would like to sincerely thank our speakers for today who have shared their experience and future vision and next step to enhance the FETPs at the global, regional, and national levels. My gratitude extends to our audience who were actively participated to enrich the discussion in the webinar. I wish you good day, night, and meet you in our forthcoming webinar. Thank you all. Thank you.
Thank you.
Thank you. Thank you, Dr. Mohanad. Thank you.